All right, I think we're ready to finish up class today. So I hope everybody had a good short break and some time, get some coffee or whatever you needed to do. Um, Thank you, Rhonda. Before I go on, does anybody have any questions? You can put them in the chat. You can unmute yourself. Any questions?
I have a question.
Yes, Tiffany.
Okay, so we're talking about the cognitive behavioral. What about I have a friend who has dealt with a lot of pain, and that was her, I guess, excuse. I don't know if it's an excuse or not, but for her to use and stuff like that way. And she told me that I'm tired of it. I just want to stop. I'm done. Like I'm tired. And she's been going for like a year and a half straight every day because of death in the family. So where does that take place?
So it's really hard to tell because it's really always on an individual level, but it sounds like uh, we're going to go over another type of therapy that is called emotive cognitive behavioral therapy, which brings in the concept of emotions, including ideas of pain and how pain can drive things like the addictive cycle or even cycles dealing with mental health. So I'm going to ask you, let's put that kind of on pause, but the cognitive people would say, well, it's happening in the justification areas where she's using her pain, maybe her loss as a justification for use because she can't find any other answers. On the behavioral, they would just argue that it's really not any of those things, that maybe the pain is a trigger, and that triggering a pain then drives the behavior. But there's I think a better explanation when we get into more emotive type therapies. So hope that is okay for right now.
Yes, it is. Thank you.
Okay, welcome. Okay. All right, so let's talk. So we kind of have combined them into this cognitive behavioral approaches. And again, the goal is to understand the thoughts, emotions, and behaviors, and then look for the distorted, irrational thinking that contributes to things like emotional distress or maladaptive. And then we identify, trigger, challenge thoughts, replace negative thought patterns to healthier alternatives. And that's kind of the goal that we'll look at when we get to, again, usually the models of relapse prevention are really good to kind of explain this process. So let's, though, go on. And I just want to talk about really quickly some other models. Okay. The first one is dialectical behavioral therapy. Okay. And it was initially designed for people who are suffering from borderline personality disorder. Okay. But is now used for things like self-harm, substance abuse, emotional dysregulation. And what DPT does is it combines cognitive behavioral therapy with mindfulness and distress tolerance. Okay. And so this model kind of uses four approaches when it comes to core kind of modules, as you would say. So mindfulness is when you're going through a crisis, when you're going through an addictive cycle, training yourself to stay present and aware of thoughts and emotions in the present time and place. Because really the idea behind this is that when we're dealing, for example, something with addiction, we're going to use our past to justify our present behavior. We're going to say things like, this time it's not going to turn out like last time. Okay, I'm not going to have that bad experience that I had. The idea is to bring the person to right here, right now, not focusing on the person's past, not focusing on the person's future, when they're going through some type of crisis. Okay. And this then brings to the second one behind kind of this approach is distress tolerance. Okay. And this is getting to the time of handling crisis without making them worse. So this is understanding that just because, for example, you chose not to drink, it doesn't mean that you're not going to be continually tested, that your withdrawal symptoms are not going to get worse, your craving symptoms are not going to get worse. This, though, using this model, it's about learning coping techniques to handle that distress, handle that distress tolerance, and be able to work through is a common term using DBT, work through a distressful situation. Okay. And then the third one is emotional regulation. And so this is managing intense emotions, how to work through those. And then the last one is interpersonal effectiveness, being able to build um, healthy relationships. Okay. So really, this model, and the reason why it's called dialectical behavioral therapy is it is a very structured, very skill-based um, 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 system. And in the group session, basically what you do is you teach mindfulness, and then you have your group members practice the skill. Okay. And probably one of the things that is very common in here is in that interpersonal effectiveness is it's actually teaching group members how to have basic conversations with each other. This is usually done really with low functioning groups that have a difficult time building relationships. And you'll have them practice things like simply being able to behaviorally say hello without being too distant or without being too needy in that situation. Okay. And so this is very much a skills-based approach. All right. That focuses on the here and now, focuses on what you're experiencing right now. Now, one of the things about this model that we should take from, if whether you agree with it or not, is current research does show that if you focus on how the client is experiencing their symptoms today, right here, right now, that they are better able to manage life, better able to get beyond whatever is ailing them. That this idea that in order for someone to improve their life, you have to go back into their childhood, you have to go look at the relationships between mom and kid and all of those things and really tear down to the history to understand really has been shown to be an ineffective approach in actually helping someone. Okay. But there is a place for that, which we will get to. Okay. And then there is existential therapies. Yes, these came from Viktor Frankl, Rollo May, Jean-Paul Satire. But I'm going to actually focus on Frankel's version of this. Frankel actually went through the Nazi concentration camps. He wrote a very compelling book that I would encourage you if you like this model to read. I can't think of the name of it right now. I think it's A Search for Freedom or something like that. But he used his experience in the concentration camp to come up with these therapies. Okay. Um, and the purpose of existential therapy is to help the person explore the fundamental aspects of their own existence, including the idea of death and mortality. Man's search of meaning. Thank you, Natasha. Yes. Thank you for getting that. Okay. And he very much focused on this idea that, hey, we're only here for a short period of time. What are you doing today? What are you doing to exist in the world today? And then he talks about freedom and responsibility. And this is actually comes out of some very interesting research from the concentration camps. Is originally military psychologists assumed that if we have so many trained military personnel coming back from World War II and they're being diagnosed with PTSD, surely the Jewish individuals that were put into concentration camps had no training really on how to deal with that situation. Their rates of PTSD must be skyrocketed. Um, and so they went and they did the assessments and all that, and they actually found out that PTSD among those who were in camps were relatively low. I mean, the most research suggests that in any type of trauma situation, anywhere from about 13% to 16% of individuals in that situation will get some type of post-traumatic stress symptom, if not the complete disorder. But when they interviewed the individuals they found from concentration camps that survived, their PTSD rates were like 3, 4%. It was really low, beyond what you would normally expect in any given crisis of that type. Okay. And so they went and did interviews to really figure out why. And it really came down to this common theme that kind of can be paraphrased by a couple of the individuals who survived that. Is they said basically the Nazis could control them, they could starve their bodies, they could take their clothes, they could separate them from family, they could do all of that, but they couldn't take away my freedom to think, my freedom to imagine, my freedom to be free within my mind, even if my body is completely trapped. And that's the kind of point of this second bullet is no matter what we're going through, we have the ability to have our mind freed from that. We're not prisoners, even if we physically are, even if we're living for this would be something Frankel would argue. Even though you're living in poverty, even though you're living in an abusive situation, even though the things that those things cannot take away from you is what's happening in your mind. That that's not controllable. And that's one of the things that existential kind of therapy tries to bring out. Okay. And then beyond that is isolation and relationships. And I'll go back to Frankel's example. Uh, what we did find in the looking at lives of individuals who survived or succumbed to the Nazi camps is the really pull my boots by my own bootstraps, strong man. Um, I take care of myself. Those individuals actually had the less life expectancy in a concentration camp. Those individuals who were that lion among themselves, that lone wolf, strong person, they tended to have lower life expectancies. It was individuals who maintained relationships, retained those individuals who snuck every Sunday to a group to practice religious things with a group and with other people and did things for others and others did for them. Those individuals in the concentration camps, according to Frankel, are the ones that survived the concentration camps. Okay. And then meaning and purpose in life. And this goes back to that freedom and responsibility that even in the weakest, darkest moments, we have the freedom in our mind to provide us something with some type of meaning and purpose in life. Okay. Frankel's meaning in life to get through the concentration camps was the hope to see his wife after he got out, to the hopes of finishing his book that he was writing when he went into the camp, the hope of seeing his family and friends. That meaning, that purpose drove him and helped drive him get through that. And that's what the existential therapy tries to do. Okay. Now, existential therapy, let's talk about this for a minute. Effective in relieving addiction and habits, managing symptomology, not so much, but providing meaning for a person to want to learn coping strategies for relapse prevention, thought stoppers for depressive symptomology, all of those things. So existential therapy is usually a very good place to start with people who are at the lowest point of their life. They don't feel there's any meaning or purpose, and they're at that isolation moment. They've hit quote unquote rock bottom. This may be a therapy to start with and helping them build their sense of who they are and meaning and purpose in life. Okay, so this may be a good starting point, but it definitely shouldn't be the only tool you use in your toolbox. Solution focused brief therapy. Okay, so this is developed by Keynes and Berg. This is really a goal oriented, future focused therapy. So remember, we just talked about the dialectical, which is about the here and now. This one, though, emphasizes solutions rather than problems. Instead of exploring the past, it helps clients identify strengths and use them to build solutions for future behaviors. Excuse me. This one is a brief therapy because it is usually used for individuals who are either going through an acute problem or individuals who, for example, notice that they're having a drinking problem and it's getting worse and worse. So maybe it's kind of like being pre-diabetic. Maybe they're in that pre-addiction phase where it's going to go from just a serious drinking problem to a completely self-destructive addictive cycle. Okay. This is very brief. It's meant to provide the person with goals because they're not completely into their cycle of trauma. It's easier for them to identify their strengths and use them as skills to stop, for example, drinking or stop the thoughts that they're worthless or hopeless or helpless. Okay. So this is a good one. And I'll tell you why it's important to kind of tease those things out. Okay. Um, and why sometimes using a less intense treatment modality is much better for an individual than throwing the whole entire gamut of everything we have towards someone. Okay. Is I remember doing research up in Montana on peer support programs. And I may have told this story already, so I hope I'm not telling it again. And what we were trying to do, so it was a peer support mental health plus substance abuse. So it was co-occurring, comorbid diagnosed individuals. So it was a person with both maybe major depression and substance use disorder, or bipolar or substance use disorder. Okay. And so what we wanted to know is at that time, you guys have probably heard of peer support programs where a peer goes in who's been through the process, has been through the treatment. They go and they take some classes on how to support other people who are going through the situation, and then they become that person's kind of support person, and they visit with them, they do activities with them, all those kinds of things are kind of their go-to person. Okay. And we wanted to know, the state of Montana actually came to me and a colleague and asked, is this an effective way of treatment? Is this a helpful part of the treatment process? And we went and measured it. All of these people were put in the same level of treatment regarding the level of symptomology that they had. So we had people who had mild symptoms, moderate symptoms, and severe symptoms. Okay. All of them got the same intensity of treatment, like intensity meaning the most severe type of, plus the peer support. Okay. What we found is in that research is when the person had severe symptomology, the peer support and the treatment seemed to work. It lowered symptoms, increased quality of life, all of those indicators of recovery from or healing from a disorder of some type. Okay. The moderate people, no effect. It really didn't predict their success or failure, increase in life, quality of life, and all of those things. No effect whatsoever. However, with those individuals who have mild symptomology, it's still significant. They're there for a reason, but their symptomology isn't as intense. It actually made their disorder worse by putting them through all of those treatment modalities. It made their symptoms worse and they became more quote unquote sick than better. Their quality of life went down, not up. Okay. And this is why I wanted to introduce these kind of more brief type therapy models, because dependent upon the intense symptomology of a client, you may choose to do a brief focus therapy for one person, but then do full-blown cognitive behavioral with some existential stuff for another person based upon the level of symptomology they come to you with. So that's kind of why I wanted to introduce more of a kind of a goal-oriented for future focused type of model. Okay. Narrative therapy. All right. Narrative therapy, developed by White and Epstein, suggests that people shape their identities through stories they tell about themselves. These stories can be negative, I'm a failure, or empowering, I am resilient. But the job of the therapist is to reauthor these stories to promote healing. Okay. This has often been used for example, with trauma survivors, people who need to don't have a really good understanding of who they are. This can be used for example, with identity development. It can be used for gender confusion type disorders when someone is confused or having difficulty understanding their gender identity, those types of things, and self-esteem building. Okay. Group members share narratives and externalize problem. I am not my depression. I have depression. Okay. And the idea is to help them re-author their life story in more of a positive and empowering way. So in the group setting, this would be someone tells a story, tells something, a trauma that occurred in their life, why it occurred, how it makes them think about who they are, and then using the group members, having the group members kind of help them rewrite that story, re-understand it from a different perspective. Okay. And the idea is that by rewriting that story, that person then will heal and become better. All right. Now, this narrative therapy model, and the reason why it's called a model is but there is no complete treatment modality based on this. This is usually used when you're doing what's called a process group. Okay. A process group is a group that a person usually goes through after they've gone through therapy. In addiction, they go through therapy, relapse prevention, and then they go to a process group. In that process group, because they already have all the skills and stuff, they're not relapsing, they then can explore their world. They can explore it in more detailed and start rewriting their world. Karina, you have your hand up.
Yes. So would a process group be like an AA meeting?
Um, I mean, so they do process in AA meetings. And so you could argue that AA has a process component,
Mhm.
but usually a process group is facilitated by a master therapist.
Mm.
And the reason, because if you're trying to recreate a story and help someone understand who they are, you
That wouldn't be
really,
a part of a process though, right? Or no?
um,
Differs?
well, when we talk about process group, and I probably should have clarified this. A process group isn't about where you are in your addictive process like AA.
Uh,
All right. A process group is where you're at such a level of health and well-being. Um, uh, I used to do process groups with survivors of domestic violence and sexual assault. Okay. And they were usually put in that process group after they went through the psycho educational group that usually is done and some type of group or individual treatment. Okay. And when they come into the process group, and this is a reason it's called process, is this is a safe place where they can start to really analyze their life and their world without their trauma or their illness interfering. Does that make sense?
yeah, so it's more just trying to explain the process of what they've been through, like
Yeah,
trauma wise. So they're okay. It's yeah, it's starting to make sense.
a little bit more. Okay. And we'll make this more clear as we move along, so I promise. Now, one, I will say this. One thing that kind of grew out of the narrative therapy approach, and I want to kind of hit this one kind of um, right away, is something known as the empty chair technique. This is where you put a person in a chair, and there's a chair that is next to them that is empty. And for example, with survivors of domestic violence, they usually say, imagine that's your abuser. Tell your abuser what you feel today, and have a conversation with them. And that behind that is kind of coming to the sense of releasing your emotions in that situation, but also being able to have that narrative in one's mind. Okay. I'm just going to put this warning out there. Please be very careful using that technique. Yes, if it's facilitated correctly and you know what you're doing, it can be a healing process. But I would not do it if you don't have the experience with doing that type of treatment and haven't make sure you have years of treatment behind you before you try it. Because I've seen where that has done a lot of damage. Karina, you have your hand up.
Yes. So, how would you deal with someone who doesn't want to approach someone that has hurt them? Like they just want to just close them out and like let it go, but also trying to help them heal to let it go.
Well, the thing is you wouldn't even address that until they've gone through the treatment that gets them to the place of acceptance of what's happened to them. And you may not even use the idea, I know in some of the treatments they have you write a letter to whoever you've hurt in your life, and then you just throw them away and those kinds of things. Um, Usually those things are done after skill development, confidence development, self-esteem development. But even at that, if the client doesn't want to do that and they're in a healthy, strong place, you don't do it. It's not something that should be required of someone. Okay. It's called the empty chair technique, Amber. Yeah, it's an interesting one. All right. Oh, wait. I just skipped a model. Okay, the other one I want to get through is interpersonal therapy model. Okay. Again, this is going to be a brief one. It's a time-limited therapy that focuses on improving interpersonal relationships, such as communication patterns. It's often done for things for depression, social anxiety, relationship conflicts. So if you become a couples and families therapist, you'll probably run into this therapy. Um, but the goal is of interpersonal therapy is is for members to explore transitions, griefs, and relationship difficulties. Okay. So this is often people who struggle with the loss of a loved one, someone who can't handle conflict in a relationship, or someone who in the social anxiety has fears of social interactions. Okay. And this again is a structured communication exercise to improve relationship skills. And it focuses on four areas: interpersonal disputes, how to deal with conflict; role transition, life changes, job loss, divorce. It goes through grief and loss. And then interpersonal deficits, such as difficulty forming and maintaining relationships. And this one is very structured. It uses, again, teach, role model, practice. Okay. So usually in IPT, the therapist teaches let's say, conflict technique. Then the therapist usually role models that with one of the participants, and then the participants practice it. Okay. So there's kind of three stages of learning. Um, Now, this one is usually used in first phases of healing for people who are going through grief and loss. Um, this type of treatment, again, is used for those individuals who are kind of on that lower to moderate level of symptomology. You usually wouldn't use ITM with someone who, IPT with someone who has severe social anxiety or depression to the level of suicidality. You wouldn't start with this one. You might end with it eventually, though. But this really focuses on interpersonal relationships and developing those. Okay. And then just some other general models. For example, the medical model. This is individuals are treated. For example, addiction is a disease, depression is a disease, and they very much focus on symptomology. And I've done that too throughout this conversation. You keep noting that I say symptoms, right? And symptom relief. That's very much a medical idea. We're going to kind of try and get away from that as we move in that kind of language, okay? That we also need to understand that there's relation, faith, and spiritual based programs. Um, Many churches have a mental health and addiction recovery type programs. A pastor, for example, has the same rights and ability as a licensed therapist. They have the same confidentiality rights, all of those things. So you've probably heard of pastoral counseling. And really, these focus on bringing back faith and spirituality. We keep mentioning the 12-step program. The 12-step program is based on faith and religion, okay? The pure one. It's where you're giving yourself to Jesus and putting yourself in his hands, in a sense, or God's hands, and they become the object of what I need to work for. Okay. And that's kind of so 12-step programs are a good example of this. Um, a lot of modern 12-step programs also just focus on spirituality, less the faith and religion aspects, in order for those individuals who may not be Christian or whatnot. So and then we need to also understand that there's also conservative versus liberal attitudes towards helping. Okay. I think this is kind of an important in this time of day. Um, um, so, for example, conservative attitudes are much more the onus of a person problem is on the individual. Okay, the individual, if they're homeless, it's because they're lazy. Um, uh, they can't keep a job. They're drug users. That's a very common kind of attitude because it's about the individual and the individual's self person. More liberal attitudes towards helping is that it's a lot about the situation, their social economic status, the people that are around, the access to medical care, access to jobs. All of those things contribute to someone's condition. Okay. Reason why this is important is when you're understanding your client, it's important to understand where their mindset about helping comes from. Because someone can be in a treatment group where the group is trying to help, but maintain that attitude that all of you just can't control yourselves, or we're all here because we're losers. That's a very conservative mindset. But you can also go too far on the liberal end. Okay. On the far, far liberal end, you could say, well, I'm here because I had a shitty childhood and I live in a poor neighborhood and it's my external existence that is creating this horrible place that I live in and I can't exist. And this is where, as helpers, we need to help individuals who are on the extremes become more towards the middle, that we do have control over ourselves and our mind, but we also need to understand how external contributors do contribute to our situation and how we can cope and handle with those. Okay, so kind of keep that in mind too, and trying to keep a middle ground and helping not extreme or polarize group members who are kind of on those different ends of why people are in the situation that they're in. Okay. All right. Okay. What time are we at? All right. I think, let me see. Okay. I think we can get through this part. What I want to do at this moment is I've been throwing all of these different approaches at you, giving you samples. We're going to break them down through the semester, but I want to give us just kind of a general helping model that, again, I want to encourage you to start practicing. Okay. So this, you don't have to do any dialectical da 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 da. This is just a way to approach someone who is asking for help. Okay. Now, in this model, we'll always start with exploration, try to aim for insight, and then try to aim for action. Okay. But you'll notice that this is done in kind of a Venn diagram because I do want you to recognize that sometimes these overlap with each other. Okay. So exploration is for not only the person who has a problem, but for you to get a complete understanding of a person's situation and problem as that person has experienced it. Okay. And we'll be moving into different what we call macro skills of counseling. So we're going to start with listening and attending. Okay. Most people listen to respond. Most people already know what they're going to say before a person is even done talking. Okay. But in the listening and attending situation, what we're going to start to do is we're going to start to practice not responding, but actually listening and attending. So, one of the skills we're going to practice is when a person tells us a problem, what I would like you to start to do is once they're done talking, simply ask, so what I heard you say, and correct me if I'm wrong. And then tell them what you heard. And then at the end, did I get it right or do I got it wrong? Is there anything I'm missing? And then you might ask more exploring questions, but I want you to start practicing that because it forces you to do one thing. It forces you to listen in order to understand instead of listening to respond. Okay. So exploration state is when you're just exploring. This is going to use the humanistic approach, building that relationship with someone, building that trust with someone. Okay. And then eventually what's going to happen is both of you, maybe at the same time, might have that light bulb moment, that insight. You come to these common themes or these common threads that the person keeps coming up, like maybe a certain person they constantly come in contact with makes them feel a certain way or makes them have trauma or something like that. Maybe every time mom or dad calls, this happens, or something like that. You find these common threads. And then based on that insight, that understanding, that moment of clarity, you then help them develop an action plan. What can I do about this? What can I do to not have this situation evolve in my life? And so you develop an action plan. Implement the action plan. If it doesn't work, you go back to exploration, insight, action. I want you to kind of get these three terms in your mind and kind of start practicing them. Okay. And yes, in the beginning, if you're doing this with your partners or maybe even your kids or friends, they're going to go, oh, you're doing that counseling thing again. Kind of go, yes, but keep doing it because eventually it will start to sound so natural that people won't think that you're just counselizing them. Okay, so I promise the more you practice the let, so tell me if I understood what you said. I give you permission to correct me, but what you stated was something like that. Practice that statement over and over and over. Eventually, people won't even notice that you're counselizing them. Okay, as I've been told, it's called. So practice that, and let's see how that goes. Okay. And again, I just want to focus on this as we start to begin this building process of developing groups and developing relationships. We want to use the centered focus theory, the client-centered focus theory, that our life is guided by internal factors, not external factors. And this is where it's important as a therapist, as a counselor, that you don't become an investigator. Our job is not law enforcement's job to find out what factually happened versus what someone experienced. That's not our job. Okay. Our job is to understand how our client has framed what happened to them in their own narrative and in their own interpretation and accepting that as their reality. Okay. And yes, especially when you are working with high-risk populations such as inmates, a correction system, those types of things. If you don't do this right, they pick up on it and they go, and then they'll start creating a narrative that makes them look good to try and get you to write a letter to the parole board or their probation officer. So I'm not saying that this can't be manipulated, okay? But when you've taken the time to develop a genuine relationship with someone, they will tell you what their real actual experience they feel was. And even though you may have facts that something else happened, you got to understand that that's their reality. That's what they experienced. And that's what you have to work with. Okay. And then maybe later you can use challenges to their narrative story as you help them develop a different mindset of what happened. But in the beginning, their reality is the reality we accept. Okay. We have an innate blueprint of our own potentialities, remembering that everyone has a motivation to self-actualization. And all issue arise in congruency between the real and imagined self. That's where conflict starts, is understanding the frame of the individual and what they think they should be or are not being. Okay. So again, the steps, the client and helper must be in what's called a psychological contract, beyond the informed consent, beyond the FERPA stuff. You actually have to be in a psychological contract that you are there to help, not manipulate or hurt. They're there to heal and overcome their situation. Okay. And you must be in a state of congruency. You need to be present. You need to be there. You shouldn't be, tapping your pen on your desk as a client is talking or looking around your office or thinking about what you're going to have for lunch. Okay. No, you and them need to be in a complete state of congruency. Okay. And you must be congruent by being genuine, okay? Or integrate into the relationship that you are, since they came to you, you are now part of the situation, okay? You must show unconditional positive regard. I promise you, if you do this work long enough, you're going to have a client who is going to tell you that they did something very, very horrific. Okay. And maybe even something potentially very illegal. Okay. But if you do not continue to be there unconditionally, despite this very negative thing that they told you, you're probably going to not even help them get over that. The treatment should just stop if you're that surprised. Okay. So getting to that moment of congruency with yourself that you can completely accept someone, even if they tell you something horrific that they did. Okay. You must experience empathy for your client. Empathy being that you feel what they feel. You may not have experienced what they've gone through, but you feel the impact it had on them. Okay. Um, Clients must experience a helper's congruency, and they must experience that you're there. And the goal of what we're going to go through starting next um, um, Saturday is we're going to go, what are the techniques? What are the skills that are necessary to develop this type of relationship? So next week, we're going to start with attending. We'll talk about what the model of encourages. Um, we're going to look at listening. And then that's going to end our introductory part. So we probably will just have a few minutes left on this introductory part. And then next week, we will get into a conversation about groups themselves. How do groups develop? And what is your responsibility as a therapist facilitator during a group's development? But that's kind of the goal we're going with. I'm going to stop the sharing. I mean, stop the